There's probably some northern lights to see in the waters tonight if we look out between our two countries, which would be great. I've tried to sort of do a talk tonight, which is going to address both migraine comorbidities, which is the sort of the common terminology used for other conditions that happen alongside migraine. But one of the biggest reasons why I even went into headache 25 years or more ago was because I was really interested by people presenting with a lot of different symptoms who maybe mentioned headache and sometimes quite often didn't mention headache. But I was really interested why some people were presenting with a lot of symptoms, and yet when we investigated them, they didn't have MS, they didn't have Parkinson's disease, we weren't finding any other neurological structural problems. And yet it became quite clear maybe 25 to 30 years ago to me that a lot of these symptoms fitted in with headache, and that's actually what drove my interest in headache disorders. I've been probably more interested by the non-headache symptoms than the headache itself. And interestingly, when we start looking at what matters to patients, I think it becomes quite clear that the non-headache symptoms can be as disabling, if not more disabling, than the headache itself. And also they can lead you down a sort of rabbit warren in terms of where you get seen, how people view you, whether you're seen as having a psychological disease rather than a neurological one, which is something I have a bee in my bonnet against, because I think a lot of people are diagnosed with psychological problems when actually it's a physiological problem of the brain. It's not a weakness of your mind, so to speak. And I think a lot of people get on the wrong path if things aren't really sort of dealt with properly. When Deirdre asked me to do this lecture, I had some trepidation because I was thinking, right, well, what am I going to talk about and how much can I fit in and how many days have I got to give this lecture? And over the last few days, I've been talking to Deirdre and we've decided to sort of arbitrarily to sort of cut this lecture in two different halves. So this is part one tonight, and I'm going to really concentrate more on the comorbidity side tonight, whereas I'm going to concentrate more on the non-headache symptoms next time, but you'll see that the two overlap. And obviously, if you have questions at the end, I'll answer questions, and we'll see some of the questions might sort of they might sort of give you a forethought of what's going to happen next lecture as well. One apology that I have got, I know that some people have sort of said, oh, the lecture's got the same things, we've already been told these things, but it's very hard to give a lecture without, so people who are new on the lectures and haven't come before, it's very hard sometimes not to go over one or two bits again. So I do apologize if there's repetition for people that have been before, but I think repetition can also be quite useful because it solidifies the important points. So without further ado, this is Tweedledum and Tweedledee, and this is Alice in Wonderland, Lewis Carroll, and it's got a particular relevance, Lewis Carroll, that you'll see either later in this talk or next time. But this quote I really liked, which was, generally I am very brave, only today I happen to have a headache. And when we were designing and decorating the new, there's a whole new building at the Walton Centre, which is for rehab and outpatients and other things, called the Sid Watkins building. And when we were doing that, we were asked to provide a single post or a scientific poster that would outline what we think about certain disorders. So there was one for Parkinson's disease, there was one for dementia. I actually gave this poster rather than the scientific one because I think it actually really sums up what happens with migraine and why people recognize it so disabling now, but around you, so many people don't recognize its disability. It's a highly invisible disorder. So having a headache can make you not very brave. I don't generally like many of the slides that come over from the other side of the pond, but I quite like this slide. And I will show you a slide later that I designed about 23, 24 years ago. And, you know, certain things that are on it, for instance, things like restless legs. I had actually been lecturing on restless legs being part of migraine for about 8 years or more before the first paper came out and showed anything that there was an association. So a lot of these symptoms, they might sound like a lot, but actually if you start looking closely at the slide, you'll think, oh yes, I've got 2/3 or more of those. Why is headache important? This slide is partly for doctors and partly for patients themselves. And I suppose as a patient, you're worried that this might be an indicator of a life-threatening disease. So I was speaking to one of my friends last night who had the COVID vaccine, whenever it was, two and a bit years ago. And then he got the first headache he'd ever had in his life and the worst headache, and he couldn't lie down and coughing made it worse. And eventually, despite my telling the doctors, in the local hospital, this guy's got a clot in his head, venous sinus thrombosis. It took a long time for the penny to drop for them and actually to listen to what I was saying and actually get on and diagnose him as that. But he's one of the really rare patients that we see where headache is an indicator of something life-threatening. For most people with headache, 99.9% or more, it will not be an indicator of life-threatening disease. But if it's a chronic headache disorder, it may occasionally have a serious underlying cause. It is commonly associated with disability, work absence, inability to function in the home environment. And then also, people who present with headaches often have the headache disorder, but it may be a misdiagnosed illness. In other words, if someone who presents with a headache disorder may inappropriately get a label of stroke or TIA or MS or sinusitis or depression, epilepsy, chronic fatigue syndrome, etc. So it's important that you recognize the headache disorder because headache disorder is very treatable. So this slide is supposed to represent a radar. So this is what the World Health Organization consider about migraine, and this is therefore above the radar. This is when people know it's migraine. So when people know it's migraine, we then look at it and we say, well, it's one of the 3 most prevalent worldwide conditions. It's said to be the 2nd or 3rd commonest cause of disability worldwide. And indeed, in women, it's not only the commonest cause of disability, but it is the most disabling. Migraine is the most disabling condition known to womankind between the ages of 16 and 50. So it's the most disabling condition known by the World Health Organization. That's comparing it with dementia, psychosis, quadriplegia, heart attack, lots of other things. It is the most disabling. 324 million people have it worldwide. When we look at a day with headache, then it's supposed to be equal to quadriplegia, psychosis, or dementia. So that's what's above the radar. But as I mentioned, that's only when it's, if you're flying above the radar and you actually see it. If you're below the radar, so this is a stealth fighter, then it may not have been recognized, it may not have been diagnosed. So if it's not recognized or diagnosed, then it's important because those statistics won't even feed in to all the World Health Organization and other data. And that's important because in primary care, certainly from the literature, the misdiagnosis rates for migraine can be as high as 60 to 80%. In other words, 6 to 8 out of every 10 people not actually being diagnosed appropriately as migraine when it is migraine. And if we take things back a century or so, and I may have mentioned this on my previous talk, and I've probably put this slide up, and I love putting slides which have musical connotations and other things. So this is Madness, the band, or Madness, the condition. So what do we actually see now, and what in the past would have been considered psychiatric? So Virtue's Household Physician, I think it was a 5-volume set of lovely leather-bound books which people had in their house from about, I think it was about 1920 or so. And they talked about hypochondria, and they put the skin will twitch in different parts or feel numb or have the sensation of spiders crawling on it. And I'm sure that many of you out there have had that symptom and wouldn't have thought yourself as being a hypochondriac. But there's a really big link between migraine and what other people think of as neurosis and hypochondria. And actually, the reason is because migraine turns up your amplifiers in your brain. So you experience much more of the outside than other people experience in terms of, the obvious things like noise and light are too much, or smell is too much, or sensation in your skin actually becomes hypersensitive. So I think that if we look at the regions of the brain, which I'll come on to later, which amplify signals, then it makes sense of why your skin will twitch or feel numb or have the sensation of spiders. We can explain all that neurologically. It's not hypochondria. And again, when they're talking about hypochondria, they have this quote, so bright sparks are seen before the eyes. I would think of that as photopsia or aura. At one time, the person will feel as large as a barrel, at other times not larger than a whipstock, which is the handle of a whip. So I'll come on to Alice in Wonderland syndrome, and I can't remember if I'm doing that tonight or next time, but I will come on to that. But that's a very clear symptom of Alice in Wonderland syndrome. The head will feel light or heavy, so a lot of people feel dissociated or spaced out, and a lot of people feel that the head is too heavy for their neck. The head may feel large or small. That comes back to Alice in Wonderland syndrome. The smell becomes perverted. I don't know how many of you out there would notice that the smell of flowers or perfume or air fresheners or cooking smells will make you really, be quite heightened, and it will be quite horrible. The hypochondriac will smell odors where there are none, which we call osmophobia. It's a migraine symptom. And I like the next one. So the person's are subject to fainting turns. In my normal general neurological practice, away from headache, I see about 40 to 50% of people coming in with blackouts don't have epilepsy. They don't have a cardiac cause for blacking out. They actually have migraine syncope. And when we recognize that, then we can treat the migraine and stop them blacking out. And then, of course, doctors like to write horrible things about patients and get away with it then. They are irritable, fretful, peevish, and fickle. Now, if I wrote that about my patients now, I'd be referred to General Medical Council. But anyway, that included, the book included a lot of really eminent authorities, really big names in the world of neurology. So coming on to migraine comorbidities. I wanted to put this slide up first because I think it represents one of the latest studies. And I think this is a study from America. It is a web-based survey. All the epidemiological studies that we have limitations according to, have you sampled the right population? Have you sampled a representative population of everyone in the world? So some studies are going to be limited to just certain countries where the gene pool might be slightly limited because that's mainly, if it's mainly a white Caucasian country, or maybe it's an Asian country, it will be limited. But this is in America, and I think if I'll just sort of point out the big ones here. So insomnia, depression, and anxiety are right up at the top. Basically, anything that's on this line 1 means that it's not any different from me. It's just the same as the normal population. As it goes towards the right of the chart, it means that it's got a higher chance of being associated with migraine. So, in other words, diabetes has a 1.37 chance of being associated with migraine, not just a 1%, not just a so in other words, if it was just 1, it would be the same whether you're migraineur or not. But because it's 1.37, it means that you're more likely to have diabetes if you're migraineur. And then if we go to something higher, say epilepsy, which is 2.3, that's even more likely to be associated with migraine. And then right at the top, we've got insomnia, it's 3.79. So I think one of the things that I will be trying to distinguish today, and I may not be able to distinguish these, but what is actually part of migraine and what is a separate condition? And I really want to get that out as a thought, because those symptoms that occur as part of migraine, if we sort of try and tease those apart clinically, we can often do that in the clinic. And I'll come on to how we do that in a minute. It's quite simple. But some of these conditions like insomnia, depression, anxiety, they may be pervasive conditions that are there all the time, regardless of whether or not you have your migraine symptoms or not. But it's quite hard to tease out from a study that's purely web-based or questionnaire-based. Very hard to pick out the differences there. All we can say is that you're more likely to have the two things together. It doesn't say that they're separate conditions. It doesn't actually say whether they're definitely linked together or they've just occurred more by chance. So things like gastric ulcer and gastric bleeding, that's not really that surprising when we consider how many people take aspirin, Nurofen, Voltarol, and other non-steroidal drugs for their disorder. So some things may even be due to treatments. So I suspect gastric ulcer and gastrointestinal bleeding is more likely to refer to the risks of the treatments people take leading to that. Then we've got some vascular things, and I'm going to spend a bit of time on vascular. We've got circulation problems, peripheral arterial disease. That's when people get problems with pain in their legs from walking because their arteries are too narrow in their legs, most commonly associated with smoking and diabetes. Angina. Further down, we've got stroke or TIA, transient ischemic attack or mini stroke. And I will spend a little bit of time in a few slides just on on vascular things, particularly stroke. We don't know why some of these things are comorbid. So epilepsy, allergies, arthritis, rheumatoid arthritis, asthma, vitamin D deficiency, psoriasis, osteoarthritis, heart attacks, vascular again, cholesterol, high blood pressure, kidney disease, and diabetes. So that's just one of the more recent large studies there. Coming on to why conditions are comorbid, I mean, it can be that migraine symptoms are diagnosed as another condition. So, for example, I would often consider that mood disorder, sleep disorder, or irritable bowel syndromes are largely likely to be caused by migraine mechanisms as part of migraine rather than a separate condition. The other thing is that people who have more symptoms generally get more checkups with the GP. So if you're going to the GP with headaches, it's not unreasonable that the GP is going to check your blood pressure and your cholesterol. So you're going to be more likely to be found to have high cholesterol or high blood pressure just because someone's looking at you more because you're presenting with symptoms. The other thing is that people with self-reported diagnosis may be more likely to seek medical treatment. I think one of the big things here is shared genes. That's very, very hard to tease out. I mean, it's incredibly difficult to even find out which genes are going to be the main genes responsible for migraine. It's not as if you have one gene. You know, if you had something like haemophilia, you would have one gene. If you had thalassemia, you'd have one gene. Cystic fibrosis, it would be one gene. In migraine, when we've looked at genetic studies, then we see lots and lots of different genes that have all a little bit of an effect. And in fact, I'm just about to start on some studies looking at which genes potentially make you respond to certain treatments. And that's really exciting, looking at genes, but that's a different story. Are they part of the same pathophysiology? So I've already alluded to this, that things like irritable bowel fatigue, insomnia may just be the pathophysiology, the mechanisms in the brain causing migraine may cause these as part of the migrainous whole spectrum of symptoms. Or is it that you've got increased awareness of symptoms because your migraine is amplifying them? So you may go to the GP with more symptoms and therefore get diagnosed as something like arthritis. So it's not unusual, for instance, for people to have pain in their neck with migraine and to have pain in other parts of their body. Now, if a GP or someone else does scans or x-rays on you, they will find evidence of arthritis because they're there in the whole population. If I probably scanned all of your necks tonight, assuming that you're all over the age of 16, if I scanned all of your necks with an MRI, I would find 100% chance of finding arthritis in your spine because we all degenerate as we get older in the Western world. So that would get diagnosed as arthritis because you have neck pain, and therefore it would show up as a comorbidity. So we have to be very careful because the web-based surveys, the questionnaires, they're not really going to sort of kneel down and get exactly what's happening in each person. They're a crude tool. The other thing I was going to mention, things like vascular risk and hormonal influences in patients with frequent migraine and with migraine aura. So we do see vascular risk and we see risk of hormones affecting particularly patients with migraine aura. So there's some link in the way that biologically people are connected there. And then other conditions may exacerbate a tendency to experience migraine. And I've put inflammatory disorders there. So when you have inflammatory disorders, you're going to have a lot of chemicals going around your body, things like cytokines that we all heard about in COVID that are going to be causing certain inflammatory processes in the body. But even if we just take a brain inflammatory disorder like MS, patients with MS are more likely to have migraine. So we see more migraine when people have MS exacerbations. I'm not saying that you guys have MS. MS has its own distinct group of symptoms that would make it a diagnosis of MS, and you would have physical signs to show for it. So don't start going and thinking you've got MS. I'm just making the point that people with MS, when they get a relapse, will be more likely to get a headache or a headache of a migrainous nature with it. And then the last thing on this slide is that things may have a shared structural biology. And I'm going to come on to patent foramen ovale before in a minute, because Deirdre did mention that there have been a few questions about that recently. So I wanted to, first of all, on those comorbidities, just talk about vascular disease. And there have been large studies. So Adelborg in 2018, for instance, did a very large Danish case control study showing migraine associations with myocardial infarction, heart attack, stroke, clots in the brain, venous thromboembolism, and also clots elsewhere like deep vein thrombosis, DVT, or pulmonary embolus. And also there's an increased risk with atrial fibrillation. which is an irregular heartbeat. If you get an irregular heartbeat and the top of your heart, the atrium at the top, isn't beating very strongly, then blood can actually build up in that area. And then when it goes back into normal rhythm, or at other times, it may just suddenly shoot off a little bit, goes around your circulation up into your brain and may cause a stroke, which is why some people are wearing Apple Watches and Garmin watches now with AF detectors on them. And that could potentially save a lot of lives in the future because it is a risk for stroke. Migraine is associated with atrial fibrillation, but the risk of having atrial fibrillation is only a tiny bit more than the general population. So don't all go out thinking, I must have atrial fibrillation, because it's highly likely that you won't. It's interesting that the vascular disease is more commonly noted in women, and particularly women who have aura. So migraine and cardiovascular disease, there are a lot of reasons why this may occur as a shared biology. So both conditions can cause increased platelet aggregations. Platelets are in your blood to help you clot, and a lot of the vascular problems that relate to clotting problems. Some people have more clotting factors. I mentioned haemophilia before as a bleeding disorder, which people they have a deficiency of factor VIII in their blood. But there's another factor called von Willebrand factor, which also is important in clotting, and that can be increased. Some patients with migraine, with aura, will be more likely to have patent foramen ovale, which I'll come on to in a minute, a little tiny hole in the heart that's developmental and been with you through your life. That's actually very common in the normal population, though. There may be shared genes between say, a heart attack and or high cholesterol causing a heart attack and migraine. There may be shared bits of genes that make one disease more likely to connect with another. So patients with migraine have a higher frequency of cardiovascular risk factors. For instance, slightly more people have cholesterol or atrial fibrillation. That's more likely to predispose them to stroke. They may have some abnormalities of the lining of their blood vessels, their endothelium. And then the one that's more controversial than any is that when you get aura and you get your visual zigzags or your speech difficulties or your difficulties with numbness and tingling spreading gradually around your body, then the mechanism for that is actually a wave of changed activity that crosses very slowly over your brain. And if any of you have seen those maps of which parts of the brain do what, then as it goes round and over your head or across your cortex, it will actually affect maybe a bit of the face, and then maybe the leg, and then maybe the arm, or it may affect the vision and then the speech, depending on which part of your brain that wave of changing activity is going around over maybe 20 to 30 minutes. So cortical spreading depression, or this wave of change of activity, it can change the amount of blood being supplied to your brain. We don't think that migraine is about blood vessels constricting. We think that the blood flow reduces if your brain is not very active, and the blood flow increases if your brain is active. And if any of you have seen functional MRI scans before, they show the changes in blood flow, and they show which areas are active or inactive based upon what the blood flow activity is like. So that's sort of potential mechanisms. As you'll see, I don't have any of the answers here. I'm just putting ideas out. I'm going to very briefly look at migraine and stroke, and migraine and patent foramen ovale. So it is extremely rare for stroke to occur in a migraine attack. It is extremely rare for stroke to occur in a migraine attack. So I really want to make that clear. We do not think per se that migraine generally causes stroke. We have all, as neurologists, seen one or two cases where migraine occurred, so a stroke occurred in the context of migraine, but headache occurs in the context of stroke, and there's a whole load of confounding factors. There are very, very, very rare cases that we discuss as neurologists where we wonder whether the migraine has had some role in causing that stroke, but we don't know why it happens. And generally speaking, when we look at the large numbers of people with stroke, migraine doesn't generally cause stroke, particularly if you do not have aura. So migraine can mimic a stroke, and don't all think, if you've had a premonitory phase of migraine where you've maybe felt irritable, yawning, craving food, neck ache, passing a lot of urine, diarrhea, You may have had an increased feeling of sensitivity to noise and light, or some neck ache, etc. That will come on before a migraine. So you know it's not a stroke because you know you've had a warning phase. Stroke has no warning. Secondly, if you have a gradual onset of symptoms, such as you get a bit of a blob of visual change that gradually builds up into like a C shape of zigzags and flashing, that's not what happens in stroke. That's what happens in migraine. But in stroke, you just lose vision. People with stroke who lose their ability to speak, and they get what we call dysphasia. They will usually have other features around it, whether it's visual change or tingling or other things. So it's not something that just comes on all at once and is there, but it's something that evolves and gets more and more, where it evolves into other things. And where it evolves and changes, that's migraine. Where it's sudden and everything happens at the beginning and stays there and just gradually improves over hours or days, that's more likely to be stroke. But as I mentioned, the risk of stroke is still very small in migraine. But those that do get it generally have migraine with aura. So patients with migraine aura have twice as likely to have stroke in their lifetime as patients without migraine with aura. And this generally refers to people under the age of 55. So this is for young people with stroke, but young people to actually get a stroke is incredibly rare in the first instance. So you're talking about twice something that's already incredibly rare. So when we see stroke in patients, it's much more likely to be related to things like smoking and alcohol excess, poor lifestyle, etc. If you do have migraine with aura, then it is sensible to stop smoking. Patients with aura have an increased risk of stroke if they smoke. It's about 8-fold increase if you're a smoker with aura. And if you're a smoker out there who's getting regular and frequent migraine, your risk could be anywhere up to 25 to 30 times that of another person. It's still quite rare because we're talking about a very, very rare event. But if you've got a 25 to 30% risk purely because of the smoking, if you stop smoking completely, and it needs to be complete, your risk of stroke and your risk from the smoking disappears within 2 years, but it needs to be complete stopping. The risk of smoking 1 or 2 cigarettes a month is actually the same risk for heart attack and stroke as the risk of smoking 30 cigarettes a day. 30 cigarettes a day just gives you a lot more cancer risk. But smoking is a binary thing. You either are a smoker and you have the occasional cigarette once every few months or 20 a day, or you're not a smoker. And the ones who aren't smokers get rid of that risk. And if you've got aura, you're going to reduce your alcohol within the safe limits. You're going to have a good diet, check your blood pressure and your cholesterol with a GP, maybe get a Fitbit or an Apple Watch, one that checks atrial fibrillation, maybe check you haven't got diabetes. So hopefully everyone's still with me. So migraine and stroke, coming on to that. So smoking, as I mentioned, approximately 8 times increase if you have migraine with aura and smoke, and it's much greater if you have frequent migraine. And then the other thing that's important is the pill, the estrogen-containing pill. Estrogens are important when you use them as a contraceptive because they're high dose. Once you reach the age of 50, or once you're using just low dose replacement because your estrogen has gone, for instance, HRT, around those sort of later years, that doesn't increase the risk of stroke. So the estrogen-containing pill does if you have migraine with aura. So therefore, we don't recommend that anyone with migraine who has had aura in the past uses the estrogen-containing contraceptive pill. So the other thing is there are rare disorders that migraine can give you migraine that also increase risk of stroke. So some of these conditions is a condition called CADASIL, which is a familial dementia syndrome with strokes and a dementia. It's incredibly rare and it shows up on scans. There's something called antiphospholipid syndrome, which gives you an increased risk of miscarriages and clots. And then there's SLE or lupus, all of which have an increased risk of migraine, part of their biology. So as I mentioned before, is it stroke or is it migraine? This slide is the summary of that. Migraine has a premonitory phase in 40 to 50% with those other symptoms. It has positive phenomena, flashes of light, tingling, versus negative phenomena, which would be loss of vision, loss of sensation. And it spreads, it evolves. Whereas stroke has no warning phase, no premonitory phase, It has pure negative phenomena. You lose feeling, you lose vision. It all happens at once and is worst at the onset. It doesn't progress and get worse. If anything, it gradually gets better. Okay. So I'm just going to talk a little bit about patent foramen ovale. Before I start this, I just want to say this is a highly controversial area, and I don't think we have the true 100% full answers. What we do have is the evidence and information available to date. So this idea came about that patent foramen ovale, this little hole between, so just to orientate you, this is the left ventricle here. This is your main pumping chamber of the heart. This is the left atrium, which the blood comes in from the veins into the left atrium. Oh, hold on. Blood comes in from the veins into the atrium. It's pumped out into your main aorta, goes around your body, and it comes back in through the lungs and through your pulmonary veins into the right atrium. So basically, it comes in. Well, it comes in oxygenated, and you pump it out, and then it comes back again through the right side of the heart. And if there's a connection between the right and left atrium, you have to be aware that this side here is under much higher pressure than this side. So the one under red, which is the arterial oxygenated blood, is pumping hard into the body, whereas the blood is coming back under low pressure from the veins into the right side of the body. And that's important to recognize, because normally with this hole, it's like a flap, and normally the blood won't flow unless you were to change the pressure system. For instance, people who do a Valsalva, they hold their breath and press, or someone who's diving might do a Valsalva to clear their ears or clear their, whatever they do when they're diving. So it's only generally when people are doing a Valsalva that you may find that things go the wrong way through this hole in the heart, and then things can go into the wrong bit of your circulation. If things come from here into here, so for instance, clots can come from your leg or your lungs into this part of the heart, and then they normally nothing really happens to them. But if they go into this side, they get shoved into your main circulation up to your brain, and they can cause a stroke. So that's the worry about this. So there has been some systematic review where people get all the evidence together and try and work out, well, we haven't got one good study that tells us what's happening. Can we put all of them together, and can we make some assumptions? And the problem with this is that there were only three large studies. There was the MIST study, there was the PRIMA study, and the PREMIUM study. But if you look at the numbers here, they're not large numbers. They're like 100 in each arm at the biggest study. That's not a big study. If I was doing a study, say, of frumentumab or Adjuvant in migraine, I'd want a study of about 900 people in one arm and 900 people in another arm, just to get the right statistics. So we didn't really have big studies. And also there were a lot of confounding factors, including the fact that, the reason this came about was cardiologists noticed when they were closing these, some people said, oh, my migraine's gone. But the problem is, and it's two big problems. One is, when people have a general anesthetic, their migraine often goes. So you turn up to your ear, nose, and throat surgeon with what you think is sinusitis. You've got pain across the cheeks here. You go and have your sinus operation, they drill it, and your sinusitis goes. It didn't go. You never had it in the first place because it's bilateral. What you had was migraine facial pain, and then the anaesthetist gave you an anesthetic, and that really, really fantastic surgeon followed you up only 6 weeks later, very quickly, and you turned around and said, my migraine's gone. And the surgeon goes, that's because I operated on your sinuses. Your sinus pain's gone. Actually, it was the anaesthetist who gave you an anesthetic. So we know that intravenous anesthetics make pain go away for months. So a lot of these patients have had an anesthetic. The other thing is that most of these patients, even if they were on the placebo, the dummy group, they would have had aspirin, and they would have had another anti-clotting agent, clopidogrel, both of which can potentially turn off migraine. So there are a lot of confounding factors here. And if you look at this, yes, some of the studies don't get completely separated from this line of one. And that one, one of the biggest ones, the MIST study, showed absolutely no benefit, and that was the best range study of all of them. That was the most well-designed one, and that showed no effect. And then this one is negative because it's still crossing the line. It's within the normal limits. And then some of them are only very, very close to that line on this left-hand side. So the data is very poor for this as to whether you become migraine-free. This study would suggest that you're 4.5 times likely to become migraine-free if you close a PFO. I don't think that's reality. And when you look at migraine days, the reduction in migraine days, again, there was a small reduction, but a lot of these lines are very, very close to the midline, or they're touching it. And I would be very, very loath to make any inference about that because they're too close to it. So statistically, this isn't good data to say, look, there's a problem here. So as I mentioned, the right to left, what are the mechanisms of a migraine and PFO? Why are these two things linked? So the right to left shunt, the right side of the heart going to the left side, maybe there are vasoactive substances like neurotransmitters or chemicals in the blood that would normally be metabolized by the lungs, but instead of going through the lungs, they go direct to the brain circulation and avoid metabolism in the lung. That could be a potential reason why you get aura. Maybe these circulating factors trigger aura because they get to the brain, whereas normally they'd be filtered out in the lungs. They may lead to stimulation of certain systems within the brain. It may even be that you have little tiny bits of debris that come off blood vessels that are normally mopped up in the lungs, but because they bypass the lungs, they don't get mopped up and then they go into your brain circulation. It may be that we don't actually have a clue why this happens yet, and none of these things are right. I think one thing that's really important, though, is when we think of aura, most people out there think of migraine, but aura doesn't belong to migraine. Aura is its own entity that may happen within a migraine attack, but it can happen on its own. It can happen with other headache disorders. It can happen for other reasons. So I think you have to be really careful about how you interpret aura. 1 in 10 people having a coronary angiogram where they put a tube into your arm, round into your heart and inject dye. 1 in 10 people who have that procedure have an aura afterwards. And that includes people who have never had migraine before. Okay, so the bottom line, PFO is very common. About a third of the population nearly have a PFO. It's nearly a third. PFO, patent foramen ovale, is more prevalent. It's more likely to be there if you have a stroke without any cause identified, if you are less than 55. So yes, if anyone has a stroke and we don't know the reason for it, we investigate for this and we look very hard, because if we find it, then we would actually close it. But there's no point screening for it because the amount of harm that you would do in screening and doing all these procedures outweighs the benefit of actually what we would find in such a tiny number of people. For most people, a PF, bearing in mind that 25 to 30% of the people have one, for most people, this causes no problems. It's asymptomatic. And there's no increased risk in PFO for migraine without aura. So if you don't have aura, there's no increased risk in having a PFO. It's only migraine with aura where they have an increased prevalence of PFO. So those with migraine with aura have an increased chance of finding a PFO. Closing it may possibly reduce the frequency and severity of migraine, but I don't think the studies are of any good quality to really know if that is actually the case. We can't have a conclusive recommendation. So, and routine screening for PFO for migraine is not recommended. And incidentally detected PFO, where someone's not had any risks from it, doesn't require closure. But the ones where we do close it are those where we think they might have further strokes. So if someone's had a mini stroke, like a TIA, or a stroke for unknown reason below the age of 55, if someone's had decompression sickness, the bends when diving, particularly if their PFO has a little bulging out, what we call of the septum, what we call an atrial septal aneurysm, if they have those factors, then we would close them. But it's not worth screening for it unless, sometimes divers will get screened for this just to make sure they're not at risk of the bends. So overall, there's a conflicting evidence regarding an association of migraine with aura and a right to left shunt in the setting of PFO. And I think clinical trials have failed to show conclusively that PFO and atrial septal aneurysm closure is beneficial for migraine. We haven't shown conclusively that this is worth doing in patients with migraine. And we're talking about migraine with aura. And as I mentioned, one of the best studies, the MIST study, if we looked at the headache cure 3 patients who had the actual closure were cured, and 3 patients with a placebo where they just opened them up and did a procedure which didn't do anything. It was exactly the same. But those who had PFO closure had more adverse events. They had more problems because of the PFO closure. It's not a procedure without risk. And then, yeah, basically, all the other reports are either very small or methodologically problematic. And most of these conclusions have come from the up-to-date publications, most recently in the last year. Up-to-date is generally considered to be the Bible in terms of reference articles for medics. The other thing, we have so many more effective and safer potential treatments for migraine that have been through very large quality controlled trials. We know their safety and everything. So I would only consider investigation in a patient with if I saw someone with very frequent migraine and very frequent and prolonged aura who had really tried all the other drugs and other treatments for migraine, or that had a TIA or stroke, or Valsalva induced an aura or a migraine, or if they'd had the bends or decompression sickness from diving, I might consider checking this. Whether I could get someone to do anything about it or not is another matter. So I'm going to come on to migraine and psychiatric comorbidity. So the main 2 comorbid sort of areas I'm going to talk about have been stroke and vascular risk. And I'm sorry it's complicated. It's a very difficult thing to simplify. The migraine and psychiatric comorbidity, I'm going to talk about a bit more loosely and a bit more generally. So there are bidirectional links between these. So if you have a chronic disease, say migraine, then it's more likely to increase your risk of depression or anxiety, just as having arthritis would, or having Crohn's disease would, or having another disorder. And yet disability may also increase depression and anxiety, and social isolation can occur with migraine. And then the other thing is that depression and low mood, there's a really good series of experiments by someone called Irene Tracy in Oxford, professor of pain and radiology. And she's done really good experiments to show that depression and low mood, things that reduce your mood, turn up the amplifiers for migraine and for pain. And so it's very important to recognize, say, someone with a chronic pain syndrome, one of the ways we try and treat that is a pain management program where we attend to mood, we look at cognitive behavioral therapies, we look at positive thinking strategies, etc. Because depression is a big amplifier. And a good example of this, and a rather extreme one. So if you imagine someone was on a battlefield and had just been hit by a bomb or shell, and they'd lost an arm and a leg, they won't feel pain maybe for 20 minutes, half an hour afterwards because of their huge adrenaline fight or flight status. And that heightened affect can turn down your amplifiers. Whereas if you actually take someone who's extremely depressed, who's just lost their life partner, who's got pain or headache, everything will become more, because they're in a situation where they're much more introverted and the pain is being amplified by the low mood. The other thing is that some patients will be diagnosed with a psychiatric disorder, but the symptoms may be purely part of migraine. And the thing I mentioned before about, is it psychiatric or is it part of the headache disorder, or is it a comorbidity, or is it part of the headache disorder? If it disappears on your crystal clear headache-free day, then it's likely that it's part of the headache disorder. So it's a bit difficult because migraine may have a phase leading up to the headache, a premonitory phase. It may have a day or two afterwards when you feel washed out. But essentially, outside of those times, the premonitory phase, the headache phase, and the aura phase, and the postdromal phase, outside of those times, if you're free of the other symptoms, your mood is completely normal, then that's a good sign that it's part of your migraine. Other little clues can be that some people before migraine will actually become somewhat hyper, and they'll actually feel really elated even. Some people get really, a bit lively before their migraine, and that's a sign that, pride comes before a fall. You get really good, and then the next day you're in bed with migraine. That's not going to be a psychiatric disorder, but it's not uncommon for people with frequent migraine to go through cycles of very high mood and very low mood. And if you see a psychiatrist, they're not going to ask you about migraine. They'll diagnose you with a psychiatric disorder causing a rapid cycling mood disorder. And that's not what you have. The other thing, I think there are likely to be some shared genes between headache disorders and between mood disorders. There's definitely shared neurobiochemistry. You know, the same chemicals in the same areas of the brain are utilized for depression. You know, the influence of neurotransmitters like serotonin, like noradrenaline, like dopamine, they're all shared between these conditions. So it's not surprising that there's overlap. The other thing that I think is quite interesting, I have been a big sort of advocate for avoiding caffeine use, not just caffeine overuse, but caffeine use in migraine. And I did meet the person who ran the Treatment Refractory Depression Centre at the Maudsley, one of the biggest centres for research in the world. And if you go there with depression that's not responded to any antidepressant drugs, and you've been sent from around the country there, the first thing that they will do is they'll take you off caffeine for 6 weeks, and then they'll see you again. 50% of the patients, now these are the most difficult patients with depression in the UK to treat, 50% of those patients come back and they're fine. Their mood's back to normal. So treatment refractory depression and treatment refractory migraine are both associated with caffeine overuse. I would argue that medication overuse also is implicated in both of those as well. And then the other thing is that you can get these short-lived psychiatric symptoms in all 4 phases of migraine attacks. You can get low mood dysphoria, euphoria, you can get anxiety, you can get irritability. So the main risk of these psychiatric comorbidities, and it's not surprising, is in those patients with more than 15 days a month of migraine. And you can imagine if you've got 25 days a month of migraine, then you're going to be, and you're also depressed with your headache disorder, or you're anxious, you know, even if it's switched off on your crystal clear headache-free moments, you're still going to get diagnosed with a psychiatric disorder, because there are very few days where you're absolutely normal. Whereas if you had episodic migraine and had these psychiatric symptoms, no one's going to diagnose you with that, unless sometimes people get diagnosed with premenstrual dysphoric disorder. And I've seen a few patients referred who have severe low mood, almost suicidal ideation in the week leading up to their menstrual period. And that's not unusual in those patients to also find other features of migraine. And some of them don't have much in the way of headache. It's the mood that's the disabling thing. So, you know, you have to look at the whole picture in these people. Migraineurs have a 2.5 increased risk of depression, somewhere between 2 and 5 increased risk of anxiety. And as I said, the more migraine you have, the more likely you are to have these comorbidities. It's said that migraine is slightly more prevalent in those who have been subject to some form of abuse in childhood, and that post-traumatic stress disorder is more strongly associated with migraine than abuse alone. Post-traumatic stress disorder often arises from previous abuse. I've certainly been aware, I used to work in London and saw a lot of patients as refugees, and I saw a lot of patients coming in with post-traumatic stress disorder, and many of them consulted us for things other than headache disorder, but almost all the patients I saw had chronic migraine, even if it wasn't their presenting complaint, even if it wasn't what they complained of. So PTSD, post-traumatic stress disorder, nightmares, flashbacks, hypervigilance, panic attacks, and low mood. That's the sort of cardinal 5 features of PTSD. Far more likely if you've had a really nasty trauma in the past, and also more likely if you have migraine. And I don't think it's unreasonable to consider PTSD and migraine together, because PTSD is about reliving events. Everything is amplified. You become very jumpy at the smallest sound. And then you think about migraine, all your amplifiers are turned up. Your noise, your light, your sound, your smell, everything's up there. So it's not unreasonable to think there's a shared biology with your amplifiers being turned up. The other disorder that psychiatrists diagnose, and they consider this to be probably the most difficult to treat and possibly the most disabling disorder in psychiatry, is dissociation, where people just don't feel real. Yeah, I bet at least 80% of you out there have that feeling quite commonly. So my clinical experience of migraine PTSD, I noted a close link over 20 years ago. I think chronic migraine and daily persistent headache in particular are highly prevalent in PTSD patients. I don't think we generally see occasional episodic migraine in patients with PTSD nearly as much. It's the chronic migraine, the ones with pretty much daily headache. And I think that they both relate to amplification phenomena. And the other thing that I think is really important is that if you have PTSD and a headache disorder, in my view, your headache disorder is essentially untreatable until we've treated the PTSD. That's a really important thing, because PTSD is really difficult to get treatment for. Yet there are two, certainly in the UK, there are two approved therapies by NICE, National Institute for Clinical Excellence. One is cognitive behavioral therapy, but the more effective one is eye movement and desensitization reprocessing. And EMDR actually is a highly effective treatment for PTSD. And I think it unlocks your potential for migraine to then become treatable. So if any of you have comorbid migraine and PTSD, I'd strongly recommend that you tackle the PTSD before we start going through lots and lots of different oral preventative medications. Yes, by all means, get the lifestyle in place, stop the painkillers, stop the caffeine, treat any sleep disorder. But unless you actually get the treatment for PTSD, I think you're going to be very unlikely to respond even to the most advanced therapies like Botox and CGRP monoclonal antibodies, in my experience. But once you've had the PTSD treated and EMDR switches it off very effectively, very quickly, in a lot of people, then it becomes very reasonable. Okay, so as I mentioned, with this section on the psychological and psychiatric manifestations and the comorbidities, most of this is by own experience. There is some literature to support this, but I think the literature is really very poor with all of these things. Okay. So having talked about comorbidities as much as I think I can, I'm going to just talk a little bit about non-headache symptoms of migraine, but beware that I will be coming on to this as a much bigger topic in the next lecture next time. So important concepts about migraine. As I mentioned before, it's a significant, reversible, and relatively invisible cause of disability. It's much more than just a headache. Migraine amplifies normal bodily sensations into symptoms, and it may present with a lot of symptoms, even where you have little or no headache. I think migraine can be very easily overlooked or misdiagnosed in real life, and migraine may commonly be kept going by inappropriate treatments, especially where there's overuse of painkillers or caffeine. So this is a picture showing genetic predisposition. This is me with my son on Halloween a few years ago. A lot of years ago. He's much bigger now. He's much taller than me. So the things here tell you that you have the sort of genetic tendencies towards migraine: travel sickness, irritable bowel, Raynaud's. You may get hangovers after minimal alcohol. You may get headaches triggered by hormones, by too much or too little sleep, by stress actually coming on, or even by relief of stress, weekend headaches. And then in childhood, you may have had childhood episodes of abdominal pain, pale rings, pale around the eyes, pale face, dark rings around the eyes, lassitude, feeling really worn out. There may be a family history of migraine. This is my definition of migraine, because I think it's worth adding the central sensitization bit, but it's a primary headache disorder. It's not because of other reasons. It's characterized by central sensitization, which I'll go through in a minute, and various combinations of neurological, systemic, and autonomic features. So it's a brain disorder with symptoms throughout the body, and its manifestations are likely to primarily relate to three different types of activity in the brain or abnormality in the brain. One is amplification of phenomena. The second thing is brain dysfunction, especially dysfunction of the cortex, the lining of the outside lining of the brain and the bit just below it. And the third thing is autonomic disturbance. So I'm just going to talk about those a bit. This is a slide that you may or may not have seen in various guises in previous lectures by different doctors or other people. Essentially, this is a sideways view of your brain. If you imagine you split it literally down here, and your eyes would be at the front here. This is the back of your head. This is your spinal cord. At the back of your head, you've got your cerebellum, which is the primitive area of the brain, which controls balance and some other things. You've got your dangly bit here, otherwise known as a pituitary gland, and just above it, you've got your hypothalamus, which is important because it controls all your hormones, but it also controls all your diurnal and biological rhythms, so things like sleep and seasonal changes and things. importantly, this is the brain stem here, and this is where your trigeminal nucleus is, TNC, trigeminal nucleus caudalis. And this sends signals up to your thalamus, which is like, if you imagine this as a hi-fi, this area is your cassette deck or your CD player, and this area, the thalamus, is your amplifier. So the thalamus gets turned up, and that amplifies symptoms and what you experience. The thalamus also sends signals out to the cortex. This bit here is just so that you know where things like Adjuvie or Framazumab, the new CGRP monoclonal antibodies work. They work on the receptors between the nerves and the blood vessels in the lining of the brain and the meninges. Okay, so that's a picture of what your brain is and a sort of schematic of showing you what to do. I talked before about cortical spreading depression, how you might get a wave of abnormal activity that gradually spreads around the brain to give you all these positive phenomena of zigzags and tingling and speech disturbance. I quite like this schematic as well, because it looks at various different areas. So it's done what I've tried to do about 20 years ago, which is try and work out which bits of the brain are responsible for which type of symptoms. As I mentioned before, thalamus, this bit at the middle of the brain here, is an amplifier. It's about sensitization. It's about sensory sensitivity. It's about increasing signals. The hypothalamus is activated in this bit here is activated in the premonitory phase of migraine, and it's got a lot of dopamine there. It's why you get yawning, craving foods, passing more urine, all those sort of things. The upper cervical nerves, you've got your spine here, and you've got your nerves going out across your shoulders. They send signals, just like the lining of your brain sends signals, into the trigeminal system at the base of the brain. And that's why when you feel migraine, you will have pain, stiffness, tightness, and aching across your neck and shoulders. And it can be anywhere in your head or face. And if your thalamus gets involved, then the pain can be in your arm, your chest, your body. That gives you pain outside of the head. And then we've got different types of CGRP and PACAP, so different types of transmitters will be affecting the blood vessels next to the nerves. And the cortex is going to affect your cognitive, this is your brain fog, your dissociation, your dizziness, your aura. And interestingly on this one, if you start stimulating the cortex or the trigeminal system or the thalamus, you can actually potentially modulate, you can change the activity of migraine. So if we think of amplification, we think of pain, tenderness, increased sensitivity to movement, noise, light, smell. And I think we think of dizziness. I think if your vestibular inputs from your ears, if they are amplified, especially if they're slightly amplified one a bit more than the other, you're going to start feeling like you're on a boat or things are moving. Your autonomic disturbances, you're all aware of nausea and vomiting or burping a lot. You may get low blood pressure, dizzy on standing up. You may get diarrhea, passing a lot of urine. You may go pale. You may get red, runny, droopy eyes, blocked, runny nose, fullness in the ear, noises in the ears. You may even get bruising or swelling. And then, as I mentioned before, the brain or cortex dysfunction is going to be your aura, your mood change, your confusion, your memory, your fatigue, and your restless legs. You all know about the 4 stages of migraine attack. Up to 85% of people may get a prodrome, only 20% get an aura. You get your headache and all the associated things you all know about. And then after a day or two afterwards, you feel lousy. And this is just a sort of political slide from a few years ago, explaining the yawning of the premonitory phase, the craving foods, the irritability and anger, and the absolute severe depression. So, you can see all of these in the politicians, but that's the sort of things that we see in patients, including things like restless legs as part of the prodromal phase. This isn't a very good slide because although it shows spreading disturbance in an eye and a hand and it spreads, these don't happen at the same time. It will start in the hand, it will gradually move up, and then it might go to the leg, and then it might go to the face, and then you get the visual disturbance. So the timing of these isn't right, but this gives the idea that aura is a spreading phenomenon. I've just got a few slides just to show you what aura how people depict it. They call this fortification spectra. And if you go to places like Holland and Germany and Belgium, you used to get these castles with sort of different areas, and this is what the fortifications look like. So that's fortification spectrum. You can see how similar it is to an artist's depiction of their aura. It's another artist's depiction which I quite like of aura and a kaleidoscopic vision change. In aura, you may just lose your vision and you may just see a bit of it missing. Or you may get this typical, this is a really good one where you see the evolution from a blob into a large C shape on different auras, someone charting their aura over time. And this sort of C shape with scintillations and fortification and flashes and light is typical, but they may be black and white. It's another one. And that one's just, I thought that's quite nice, actually. It's a really artistic form. And then the recognized non-headache symptoms of the actual migraine attack are huge. And they, you can read those yourself, but there's just everything in there. You wonder why there's comorbid mood disturbance with irritability, depression, dissociation, anxiety, fatigue, irritability, agitation, anger, rage, all the way through even to coma, hypomania, amnesia, exhilaration. That's just a mental state. And then word finding difficulty, stuttering, dysphasia, fainting, syncope, hemiplegia, hallucinations, restless legs, twitching, periodic limb movements. You can see edema, swelling, hair loss. Gastroparesis is why you burp a lot in migraine. All those things there. And then the autonomic symptoms, which I've already talked about in the eyes, nose, ears, and skin, and also systemically. That's just a picture of what it might look like with a red eye and a slightly droopy eye. And these are the final slides. Pain in migraine can be anywhere. If your thalamus is turned on, you can get pain in all these areas. But quite commonly what's experienced as pain is actually restless legs. And if it's just when you're sitting still and worse towards the evening, that's restless legs, often kept going by caffeine and painkillers. Worth stopping those, 60% or better. And if it's not, it's sometimes worth treating that. So migraine pain can be anywhere. And then just as a taster for what's going to happen next time, that's the slide that I wrote about 25 years ago. 20 years ago. No, it's probably 2022. About 22 years ago, I did this slide. And you'll see on it, it had things like restless legs, periodic limb movements, memory, blackouts, fibromyalgia, neck pain, fatigue, weakness, dizziness, dissociation, and migraine vertigo, panic, anxiety, mood change, hallucinations, Alice in Wonderland, and autonomic symptoms. And I didn't do this from a textbook. I did this purely from what my patients told me. And that's asking questions over and over again. If someone tells me something, 25, 28 years ago, I would ask the next patients about that symptom and I would build up a picture. And now I went to a recent talk at the Royal College of Psychiatry, was that about 3 years ago. And there were 3 different lecturers there. We were all chosen completely separate to each other. And we all came at it from one from psychiatry, one from rheumatology, and myself. And we all came out with almost the same slide based on our experiences. And actually, this is out there in the literature, really. And on the crystal clear headache-free day, if these things disappear, it's a migraine symptom, not a comorbidity. So I'm going to stop there, and I'll just put some details there. This is the booklet that I wrote for the NHS Vanguard, the Comprehensive Migraine Guide, which has a lot of this in it. I got recently criticised by a patient because they said, all you did was ask the questions that was a standard questionnaire when you saw me in clinic. And you just copied someone's questionnaire, and I didn't have the heart to tell them that I wrote the booklet which talked about all these things. The British Association for the Study of Headache is a very dry but very useful resource for looking at how we manage headache per se. And then if anyone actually wants to see me as a video consult, there's some details there if they want it. On to questions. Thank you very much.